Hello, today we have evidence review, antidepressants for frail older adults with depression or neuropsychiatric symptoms of dementia. And for some reason, just at the end of our webinar, we'll have a Q&A session. And please submit your questions online during the presentation. If you wish to direct your question at one of the three presenters, please do so, and we will answer as many as time permits. We will also have the option, if we can't get to all the questions, of providing you with an email at the end, and you can email one of the presenters directly. Having trouble with my screen. Here are the upcoming webinars that have been scheduled to date. Please go on our website. You can see the list for the next, I think, 6 months. And please register. I think they've all been set up in GoToWebinar. So I won't go through all of them right now. And we have a SSA, which is our summer student program. And it just went out. Have seen the email, and you'll see on there our website of where all the information is to apply. Now on Wednesday, February 15th, that's when the intent to apply is due, and if you don't have an intent to apply, you can't go on to the second stage of the application, and the application is due February 28th at noon. We also have our national conference coming up, and the registration should be open by next week. It is April 23rd and 24th at the Chelsea Hotel in Toronto. Emails should be going out to all network investigators, our previous SSAs and fellows, and with more information to be provided. So here we have three presenters today, and they are going to take turns giving specific parts of the presentation. So the first presenter will be Lori Mallory. She's a professor of geriatric medicine at Dal University. She's a physician at the Center of Healthcare for the Elderly, based out of the Queen Elizabeth II Health Sciences Center. We have Constance LeBlanc. She is the Associate Dean of the Office of Continuing Professional Development at Dal University. She's the Associate Professor and Director of Education of the Department of Emergency Medicine at Dal University. And we also have Mike Allen, who works as a family physician in rural and urban areas of Nova Scotia for the past 17 years before joining the Continuing Professional Development at Dalhousie University in '94. He is currently retired but still contributes to this project. So please, Lori, start the presentation. Thank you.
Thank you for inviting us here today to present our work. And just like to start out with a brief introduction about why we chose this subject. We all know that the topic of frailty is receiving more attention, but sometimes as disruptors, we think that in developing our principles associated with frailty, maybe sometimes we accept some standards without adequate consideration. And so we call this putting the cart before the horse. And we thought when we were looking at topics to review in terms of medication use, we thought that maybe depression was one of those topics that needed more consideration in frailty. And we start with the status quo, which is what most people think, with the statement, late life depression remains underdiagnosed and inadequately treated. So we wanted to see if that held true after we reviewed the evidence. So our learning objectives today is first to learn an approach to evidence review for treatment effectiveness in frail older adults, and to understand the evidence for the efficacy and safety of antidepressants for three conditions that are common with frailty. So for people who are over the age of 65 with depression, those with depression and dementia, and then finally those who have behavioral problems that are associated with dementia, what's also called neuropsychiatric symptoms of dementia. So our group has worked a lot to tackle polypharmacy, and I'm sure all of you online, because you work with Frailty, know that taking many drugs is common as people age and as they become more frail. One statistics that people quote is that 2/3 of individuals who live in long-term care take 10 or more medications. And there is now work being done to see if we could do a better job in terms of polypharmacy. And the most common way polypharmacy is approached is based on guidelines that recommend avoiding certain medications in the elderly. And that's known as the Beers criteria and the stop-start criteria. And they tell us things like don't use benzodiazepines and don't use neuroleptic medications. Our group typically takes a different approach. We critically appraise the medication use in Frailty, so we look through the evidence to see if we could develop evidence-informed guidelines. And so we've done that for several topics. First one was diabetes, where we found that it's probably good to keep an A1C above 8 compared to lower than 8%. We've looked at guidelines and made recommendations for treating hypertension and Frailty, and we just finished a review of statin use in Frailty, and all of these are published with the statin article in Press. So we now turned our attention to the use of antidepressants, and the reason why we did that is because they are quite commonly used in Frailty, and this statistic shows that that's the case. In long-term care, where older people are frail, 58% of them use an antidepressant, and it's the second most commonly used medication in that environment. So to start, we wanted to figure out how the diagnosis of depression was made in long-term care, because when you read things, it says that nearly 50% of people living in long-term care have depression based on symptoms or a diagnosis. And most of these articles, when we review them, we find that these statistics are based on information from an assessment tool called the minimum data set, or the RIDE tool. And so we questioned, first of all, the diagnosis of depression and Frailty, and wondered whether these data were reliable. And one of the reasons being was because if you look at the MDS and how it diagnoses depression, there isn't a lot of overlap between the DSM-5, which is typically how we make a diagnosis of depression, compared to some of the symptoms that are being screened for in the assessment. And so some of the different aspects of depression that the MDS relies on involves feeling angry, repetitive health complaints, having unrealistic fears, being anxious, being sad, pained, or worried, or crying. And we thought that maybe some of these symptoms might be a common reaction to living in long-term care, where there are a lot of losses and a new environment to adjust to.
So it's Mike Allen here. I'm going to continue on. Tanya, could you go back to the previous slide just for a second, please? So one of the things to note about this slide, too, is that only 3 of the criteria on the left are matched by the DSM-5 criteria for depression, so there's not a lot of overlap there. So I think it's important to remember that. Okay, Tanya, let's go to the next slide, please. So now we'll talk about how we approach this topic. And we did searches of PubMed and the Cochrane Library, and we looked at recent meta-analyses and systematic reviews and guidelines, and searched for relevant citations within those. We also got some help from CADTH, the Canadian Agency for Drugs and Technology in Health, who helped us with literature search. We concentrated mostly on double-blind randomized controlled trials, and we used the PICO structure to help refine our research. So the population that we looked at was people 65 years and older with or without dementia. The intervention was virtually all antidepressants except for the MAO inhibitors, which are certainly not indicated for the frail elderly. The comparator groups that we looked at were placebo, that was our comparison group, with or without counseling. And for outcomes, we looked at response or remission on various depression scales. So for response, we defined that as a 50% or more improvement on scales like the Hamilton scale, the Montgomery-Ashburg scale, or the Cornell scale, or much or very improved on a global improvement scale. For remission, we looked at defined cutoff criteria for those various scales, and these definitions were in keeping with what was used in the literature. Doing it this way gave us dichotomous outcomes, and using that data, we performed a random effects meta-analysis using comprehensive meta-analysis, which is a program that we have for doing meta-analysis. We also looked at this data on a continuous basis, continuous scales, and didn't find any difference between that and what we and our analysis using dichotomous data. We assessed the quality of the studies and the risk of bias. To assess the risk of bias, we used the Cochrane risk of bias criteria, such as whether or not there was random sequence generation, allocation concealment, blinding of participants and researchers, how completeness the outcome data was, and how, if there was any selective reporting, and other biases such as industry funding. We also looked at other indicators of study quality, such as sample size, consistency of results, how applicable they were to the frail elderly, how precise the results were, how much heterogeneity there was, the appropriateness of statistical tests, the drug dose and whether or not it was applicable, and the duration of the study in time to benefit and how relevant that was to the frail elderly. And then we came up with an overall quality of evidence based on the grade criteria, high being systematic reviews or rigorous RCTs, moderate being RCTs with some important limitations, and low being RCTs with multiple or serious limitations. And each study was independently appraised by at least 2 team members, and if we had any differences, we resolved those pretty quickly with discussion, or we brought them to the whole team. Next slide, please, Tanya. To help organize our thoughts, we addressed 5 questions, and these are the same 5 questions that we've used in the previous reviews, such as on statins and on antihypertensives that Laurie mentioned. So we looked at, we considered what is the quality of the evidence, and I just reviewed how we did that. We considered how does the study population compare to those who are frail, and what is the potential benefit, and are the outcomes of benefit clinically relevant to the frail. I'll take a minute to explain that. This was not much of a consideration for this particular topic because the scales are pretty standard and they are applicable to the frail elderly. But for things like statins and antihypertensives, we have outcomes like stroke and myocardial infarction. And we thought that for the frail elderly, the ones that are really relevant to them are the ones that are symptomatic, so leave them with some symptomatic sequela, such as heart failure or angina or some sort of physical disability as a result of a stroke. So that these symptomatic events we thought were much more relevant to the frail elderly than silent events or even fatal events, because the frail elderly have a limited time lifespan anyway. So for studies like that, like statins or for topics like statins and the antihypertensive. We looked at symptomatic events as being relevant to the frail. Going down to number 4, we considered whether the time frame was appropriate. Do these drugs work in a time frame that's likely to be helpful to the frail elderly? And of course, what are the potential harms? Okay, Tanya, next please. So now we'll get into some results from our first clinical question, and our first clinical question was, are antidepressants effective for the frail elderly with depression? So they just have depression, they don't have dementia, just depression. And this is a similar table to the one that Laurie showed you. And in the left column, we've got the criteria for depression as outlined by the DSM-5 system. So these are the DSM-5 criteria for depression. On the right-hand column, we've got characteristics of frailty that are used to help determine frailty. And you can see there's a lot of overlap here. The top 6 domains are common to both. So that makes it difficult to diagnose depression with certainty in the frail elderly, because are some of these symptoms due to depression, or are they the result of the physical and psychological changes that come with being frail? So I think that's an important point to keep in mind. Tanya, could you go to the next, please? So these are the results of the efficacy of antidepressants for people with, older adults with depression. We had 9 studies, looked at 9 studies with over 2,600 patients. Generally, the people in these studies were younger and healthier than the frail elderly, and they had moderate to severe depression. There was one study that was about, that studied a tricyclic, and we excluded this study because these are not recommended for the frail elderly. Now, for response and remission, the results showed no statistically significant benefit versus placebo. However, we think it's important to point out that the lower confidence interval, particularly for response, approaches 1. So just looking at the results for response, 45% of people on antidepressants responded, but you may remember is a 50% or more decrease in the rating on a certain depression scale. So 45% or more of people on an antidepressant responded versus 38% on placebo. This is a relative risk of 1.16, and the 95% confidence interval around that are 0.97 to 1.38. The 0.97 is very close to 1, and as a matter of fact, if you include that study with the TCA, it becomes statistically significant. So we thought we can't really say that there's, with certainty, that there's no response to antidepressants, and I'll come back to that in a second. For remission, the results are somewhat similar, but not quite as marked as with response. 33% versus 29% undergoing remission, which is achieving a certain level on these, a certain predefined level on these depression scales. Relative risk of 1.11, confidence interval 0.93, which is not quite as close to 1 as that for response, to 1.33. So go to the next slide, please. And this is the forest plot for response. Just draw your attention to the very bottom line there, the overall response. You can see that diamond, that's the summary effect. Thank you, Tanya. Tanya just pointed it out for us. You can see that, and to the right of that favors antidepressant, to the left favors placebo. Most of that diamond is in the favors antidepressant side of the graph, but it is still overlapping the line of no effect, indicating that it's not statistically significant. Go to the next slide, please. So our conclusions from this, from our clinical question 1 so far, are this is antidepressants in frail adults with depression, are that it may be difficult to differentiate the symptoms of depression from the physical and psychological effects of frailty. The evidence for efficacy is uncertain. The data does lack statistical significance, but because of the points that I raised before, it does not exclude that some patients may benefit. Therefore, we're suggesting it's not unreasonable to start patients on antidepressants, but they should be reassessed after 8 to 12 weeks, which is the length of most of the studies. And if there is no response, the drug should be discontinued over 2 to 4 weeks. I think the next is from Lori.
So we're still on question 1 where we're asking whether antidepressants are effective for older people with depression. And Mike has reviewed the first part of that question where we used age as a marker of frailty, because we know that frailty increases with advancing age. And at this point, we wanted to look at common comorbid conditions that are associated with frailty to see if those groups had a response to antidepressant medications. And so we're not going to review, I'm going to just backtrack on that. So the second part of this review is to say, well, if the first medication isn't working, which we've seen that it might not in many cases, will a second medication work for those who are what we call treatment resistant? And here we found no evidence that related to older adults. And so we had to look at the body of evidence that involved younger, generally middle-aged people and much healthier populations, populations of people who generally had depression for long periods of time. And the common approaches that are used are, 1, to switch to a different antidepressant altogether, to 2, augment the first antidepressant with a second one from a different class, or 3, augment the first antidepressant with another medication that's not an antidepressant but could be something like a neuroleptic or antipsychotic. And so when we view this evidence, we're not going to present the details here. We found that even in younger cohorts, there is uncertain benefit for most strategies that are used to treat treatment-resistant depression. And of the studies, antipsychotics and lithium showed the most efficacy, but that was at the expense of significant adverse events that will almost certainly limit the usefulness for those who are frail. And so, as I was saying before, the next part of our review had to do with people who had comorbid chronic illnesses, and there we asked the same question: do those groups of patients benefit from antidepressants? And again, we're not going to review the evidence in detail because of time limitation, but generally we found that for people who have stroke, Parkinson's disease, and heart failure, there was limited evidence to show that antidepressants actually help and improve their condition of depression, with the exception of using tricyclic antidepressants to improve depression and Parkinson's disease. And when we look at the status quo, most people aren't using tricyclic antidepressants anymore because of their adverse effects. So our next clinical question, 2, was whether antidepressants are effective for those with dementia and depression. And we're going to review this evidence briefly, starting with the same approach of what is the overlap between symptoms of depression and dementia. And I think here you could see that there's a lot of overlap. decreased mood, loss of interest, weight gain, reduced activity, fatigue and loss of energy, trouble concentrating and feeling guilty and worthless. Those are all things that commonly occur in the course of depression and dementia. And so the first query that we had is, how do we differentiate the two conditions to even make an accurate diagnosis? We looked at 6 studies which involved 597 patients. People had low MMSE scores between 17 and 23, and the meta-analysis that we did showed that there was no statistically significant benefit in terms of response or remission to using antidepressants to treat depression when a person had dementia. And this finding is consistent with other people's work who have done similar meta-analyses. So our conclusion and recommendations on this topic, question 2, was that frail elderly patients with depression and dementia are unlikely to benefit from antidepressants to treat depression. The use of antidepressants should be the exception rather than the norm. If antidepressants are used, they should be given over a discrete time frame with evaluation of effectiveness regularly before long-term use.
Okay, it's Connie. I am going to discuss clinical question 3, and that was, are antidepressants effective for those with the neuropsychiatric symptoms of dementia? So we know that those are common and reviewed the literature in this area. The main findings are, there was a Cochrane review with 9 RCTs, and all of that evidence turned to be inconclusive for benefit, so no clear benefit. 2 additional RCTs that were that we reviewed in more detail were the Barak paper and the Forstensen paper, the CITAD paper. So the Barak trial had was a small sample size, 40 patients, and there was no placebo. And they looked at escitalopram 10 milligrams versus risperidone 1 milligram, and they didn't see a difference in their small sample in between those 2 medications. Now the Forstensen paper, the CITAD trial, so that's citalopram in Alzheimer's disease trial, that one had 2 arms. It's a convenience randomized controlled trial. So it's a convenience sample where the physicians identified patients who had dementia. They had to have an MMSE between 5 and 28. There were 186 patients. They were divided into 2 groups. And one of them got, they all got intense psychosocial interventions, so coaching for family members and other psychosocial helps. And one of the groups got a placebo that looked exactly like the citalopram, and the team didn't know. And then the other group got citalopram, and they got it at 30 milligrams a day, where the recommended dose would be 20. So they kind of went a little bit above. And in that group, they were looking at the primary outcome was the neurobehavioral rating scale agitation change for patients. There was a difference on the 18-point scale of 0.93, so not one entire number. And then the modified Alzheimer's disease cooperative study in clinical global impression of change, the MADIX is what I've been calling that, and there was an odds ratio of 2.1 of being better. Secondary outcomes, they looked at the Cohen-Mansfield Agitation Inventory, the NPI, their activities of daily living. They also looked at caregiver distress, cognitive safety using a mini mental state exam, and then they looked at adverse events, which Mike Allen is going to review in a minute. When we get to the secondary outcomes, the caregiver distress on the NPI was statistically significant, but when you're assessing something on a scale of 60 and caregiver distress was decreased by 2.7, is that really clinically significant? Is that a difference that's not a difference that I think you could leave somebody home and go shopping? I mean, this is a very small academic difference, perhaps. when it comes to cognitive, there was some cognitive worsening within the citalopram group. So their MMSE went down by 0.73, but when we look at Howard's work in 2011, their conclusion was that your MMSE had to change by 1.4 to have a clinical significance. Now, within these changes, there were within the group on citalopram, there was heterogeneity in that some patients within the group fared better than others when it was analyzed in greater depth. Those with a lower degree of cognitive impairment, those who had only moderate agitation, all of these patients had agitation, and the ones who were in the middle of the range age-wise, so not the youngest and not the oldest, but the patients who were between 76 and 82 seemed to do better. So the conclusions and recommendations here for antidepressants aimed at treating the neuropsychiatric symptoms of dementia. There's a lot of uncertainty about efficacy of antidepressants for those with behavioral symptoms of dementia. The time needed, these people used 30 milligrams a day in the treatment arm for 9 weeks before they decided to discontinue it. We were saying, mostly people use 8 weeks and sometimes stretch it out to 12. This one was done for 9 weeks. The time needed to get benefit was up to 9 weeks, which can be impractical if these symptoms are very significant. And our conclusion was that it would be important for families to be aware that these drugs are going to be of limited use and not likely to be beneficial, although there may be times when a 9-week trial, especially in that optimized heterogeneity group who benefited more, in that group it may be wise to try them for 9 weeks.
I'll do the wrap-up here. So this is a summary of the some of the data that we found on safety. Many of the adverse events were generally minor, such as nausea, diarrhea, and so on, headaches. But we did find that withdrawal from studies was about twice as common with the antidepressants than with placebo. Now for question 1, this is people with depression but without dementia. We had more data. We had 7 studies with about almost 2,400 patients. 13% withdrew in the antidepressant group versus about 6% in the placebo group, which was a number needed to harm of about 13. For question 2 and 3, these are both people with dementia, and because we had smaller studies and fewer studies in these 2 questions, we combined them to look for adverse events, thinking that all these patients had dementia, so maybe it's reasonable to try and combine this data to look at their adverse events. And it's a similar story. About twice as many people withdrew from adverse events in the antidepressant group. The most common, most frequent adverse events were fatigue, nausea, constipation, dizziness, and diarrhea. And so for some reason, adverse events were more frequent in the people with dementia than those without dementia. We also found a population cohort study of 60,000 people that found an increased risk of falls and hyponatremia with the SSRIs. Let's go to the next slide, please, Tanya. So these are our overall conclusions after all this. The signs and symptoms of frailty and dementia significantly overlap with the DSM-5 criteria for depression. The prevalence estimates of depression in long-term care may be inaccurate. So considering that, it's not surprising that antidepressants have a smaller effect than is commonly acknowledged. Individual patients might benefit from antidepressants for depression, but those with dementia are less likely to benefit. It's reasonable to try a course of antidepressants for depression for 8 to 12 weeks, but taper off if there is no response, and don't be surprised if there is no response. Antidepressants for neuropsychiatric symptoms are unlikely to be of benefit in a clinically useful time period. And finally, the risk of withdrawals from adverse events is approximately twice that of placebo. That's our study. We'll just have a couple of slides now on dissemination. Go to the next, please, Tanya. We have developed this decision aid with the help of somebody else in our department at Continuing Professional Development who's doing a master's program on using or prescribing antidepressants for depression. And if you go to the next slide, please. And we've also done several continuing professional development programs to family physicians around Nova Scotia. We have a community hospital program where we send speakers out to provide education and discussion to family physicians in communities around the province. And we've also done a webinar where we reach people who can't get to those programs. So we're starting to do our dissemination now. And now we're open for discussion.
Thank you, Lori, Constance, and Mike, for your excellent presentation. I have a few questions, other than the questions that keep coming fast and furiously because I missed the slide saying that the webinar and the presentation slides will be up on our website. And the link is on on your screen right now. And so some of the questions we have here to start with is, how do you think the findings and recommendations will be viewed by clinicians?
Well, I mean, I'm an emergency physician in my practice, and I think physicians are pretty desperate to have treatment for some of these symptoms, and so it's hard because there's not a lot on the shelf that people can reach for. So I think they're going to struggle with these recommendations.
We've had two experiences that answer that question. The first is we did present this review to the geriatric psychiatrists in this hospital, and they were a bit upset with our message. We then had the ability to present it to family doctors using a webinar methodology, and their feedback was that this message really matched their experience of day-to-day treatment of people who were frail. So, I think, I said early in the webinar that we're challenging the status quo, and we realize as we do that, it's not always going to be popular, but this is based on evidence, and it does try and tackle the question of why are so many people who are frail being treated with antidepressants.
And it's Mike, just to echo what Laura said about the webinar, the family docs quite appreciated the message because they're looking for ways to decrease their prescribing for their frail elderly. They struggle with it all the time. So this message was useful for them.
Okay, that's good to hear. So here's an interesting question. I'm not sure if this was covered in your study, but antidepressants, particularly SSRIs, have been suggested as treatments for other symptoms such as appetite stimulation, pain, etc. Are there any data on whether if there is a role for SSRIs in these situations? You may not have covered that in your...
Not cover that in our review. I could comment based on my knowledge of the area, but I think it would be better to just stick with the topic that we reviewed.
Yes, we had discussion about that, whether, how broad we should make this inquiry, this review, and we decided we had to focus on the two most commonly used indications for the antidepressants, and that's why we limited it to depression and neuropsychiatric symptoms. So the answer is no, we don't have any information about that.
That kind of fell outside the scope, which is understandable. Here is another interesting question. If a frail elderly with dementia is already on antidepressants with some initial positive results, what is the evidence regarding reducing and elimination of the antidepressant?
Well, there hasn't, as far as I'm aware, there has not been a study on that provides enough information as to whether to stop or start. But the issue of trying to assess a response is a bit complicated because we look at an N of 1 trial where we use a treatment for a particular individual, and then there's a response, which really, if you look at the literature, that wouldn't be unexpected because there is a significant response in the placebo group for all the 3 conditions that we reviewed. So I think you have to look at the whole situation carefully, look at the symptoms, the description of benefit, and then make a decision about what to do.
And in the citalopram for neuropsychiatric symptoms, in the CITAD paper by Torstensen, they actually excluded patients if they had had major depressive or psychiatric psychotic episodes previous to being considered for the trial. So those patients who would have had significant major depression with psychosis would have been not included. So that makes it difficult for us to have any data on them.
And most studies were about 12 weeks. The longest duration of most studies was about 12 weeks. So there's not very much long-term data on the use of antidepressants. There were a couple extensions to 24 weeks and 39 weeks, and the results were similar for those extensions.
And I guess it would be different if you had a patient who came to you and was on an antidepressant that had been started for these symptoms and was not a long-term depressed patient. You could then consider the somewhere between 8 and 12 weeks if there's no improvement, and if you had a way to measure those data, then make a decision based on that. But outside of that, it would be very difficult.
Any more comments on that? No? Okay. So one of the questions is, do you have suggestions for dissemination and implementation of our findings, and what were the barriers and enablers do you foresee on this? It's similar to the question that I think we talked about at the beginning. What other implementation strategies are you planning, and what, I know you've already started doing a lot of dissemination of the findings. Is there other things that you want to do, that you want to share with the group?
Well, actually, when we submitted that question, there was, I think, a bit of a misunderstanding because we thought that question was going to go to the audience, and we were hoping to get suggestions from them.
Yeah.
It was a question to prompt interaction with the audience.
Yeah.
So
Yes, there's a further question, though, coming up on saying, what are your plans in the future to further disseminate this knowledge?
Well,
I know you.
This
Sorry,
is
go ahead.
we know there's a number of initiatives tackling polypharmacy across the country, and we've been in touch with collaborators. And we would be very interested in working with others to be a site on a national initiative to tackle this. We don't know the best way to address it now. I know there's been some success with Dr. James Downer's work in Ontario, working in hospitals and doing facilitated medication review. So that might be a strategy that we could incorporate. There's also in the media been discussion about changes to the long-term care culture, and those don't need to be expensive. It's things like bringing in plants and pets and bringing in more visitors and giving the residents more meaning in their lives. So thinking about ways to redesign how we do elder care in long-term care.
Yeah, that's a unique approach. Yeah. Is that Constance? I think that there's been some work done in the U.S. that has actually, been controversial in terms of disregarding some of the rules and doing what you just said, and having a smaller long-term care facilities where patients are closer to their meals and have plants and animals, and they've had some good results with that on a small scale. But so that's a good suggestion, and I know there's a lot of work being done in the long-term care sector right now in terms of medication, and actually CFN is looking into how we can get all of our principal investigators as well as others working in this area so that we can look at optimization of medication and what's out there, what are the gaps, and so and there's lots of groups that are starting, for seniors, for frail elders. So I think that's something that you'll see in the next few months is something that we're working on, and we'll invite everyone to those meetings so that we get a large input on that, both nationally and internationally. And I don't see, was there anybody internationally on your team, or because it was a knowledge synthesis that you would have looked at? Right, go ahead.
And also I was going to say, in terms of dissemination, the groups who work together include our program called The Path, which is Palliative and Therapeutic Harmonization. And so we do a lot of training to better understand frailty in a novel way. We train teams, we do presentations commonly to groups of people that are outside the frailty circle, such as cardiologists and surgeons. We have a website as well that hosts these guidelines. We also plan to write a paper and have this published. And then Connie, maybe you want to talk about your work in CPD and how that could.
Yeah, I mean, in CPD, we're because I'm an emergency physician partly, we see patients who are on horrific lists of medications, and I have several pictures from my practice where patients are on 20, 25, 30 drugs, and it doesn't take me long to collect these, and they are presenting with falls and hip fractures and things. We've been doing some work in trying to reduce polypharmacy. We've also been doing work in collaboration with David Gardner at the College of Pharmacy, looking at reducing the use of benzodiazepines, not only in the frail elderly but across the continuum, because once people are on those, they have difficulty discontinuing them. They're hard drugs to get off, and although they're cheap cost-wise, they are not cheap consequence-wise. So it is an interest for us. We have an academic detailing service that's paid for by the provincial government here, where many of the undertakings, the statins and the hypertension work that Lori has done has been in collaboration with that group to look at best practices in prescribing and reducing unnecessary prescribing across the continuum of care, so in all patients, and that's that's a process where pharmacists go and detail physicians, much like a pharmaceutical rep would, but they peddle evidence. So we've been fortunate to have funding for that for a long time, and Mike was very involved with that, so he might want to comment as well.
Mike, did you have a response to that?
I was just, I'm thinking about that. I guess we could do it for academic detailing, but we have a new academic detailing director now, so it would be up to her.
Okay. Yeah, Constance, I thought you said that some of your people that you see were on up to 20 medications?
Oh, easily. I could send you photos of patients' medications. Some of them have them in these little dispensing packets that they pull off out of a roll like toilet paper. And then some of them come in with their medications bubble packed, and we'll send them home with 2 new ones. Or I have some of them that we pile up like little pyramids and take photos of. I would share those photos. They're mind-blowing. And I can get those on the daily in the emergency department.
And can I ask you a question? Is that prescription drugs or some of that vitamins and herbs and?
Often they're prescription drugs. Sometimes people add their own things. They don't tend to bring their own things with them to the emergency department, so we don't chase that bit down. Then that eludes us. And so if you're not a little bit finicky about it, we could miss all of the non-prescription drugs, which I think probably happens quite regularly.
Yeah, I see. I think what you've indicated in your study and what's been indicated, across Canada is that there's 10 to 12 average prescription drugs that frail elderly are taking on a daily basis. So I think there's lots of work being done on it, and we're looking to somehow, put all the people in one room and try to figure out solutions going forward so we can actually implement them. But yeah, that's very scary.
So I'm wondering if there's a way we could just have like a little query to the audience of how they receive this information, whether they find it too radical. Do they disagree with it? Is it in context with their experience? Do we need to do more convincing, or are they already convinced that we're on the wrong track? Is there a way to get just a response from the audience about those questions?
Well, we do have, and on your screen you'll see that there's a survey that will pop up after the screen. Sorry, after the webinar, and there's an opportunity to ask questions or, pardon me, give feedback. So
yeah, but I just meant in a way that we could have a further discussion about that, and that the audience could experience other people's thoughts on this topic besides our own.
Yeah, normally if there's a smaller audience, we're able to do that. Mm-hmm. Pardon me, I've got something in my throat. But there's over 100 people on.
So maybe some people could type in, some of their thoughts, and we could review just a few of them.
So I think we're close to running out of time. So I think what I could do is feed those back to you, and maybe we could do a follow-up webinar at some point if you're interested. Pardon me. So I think we're at the end. There is still a few questions, and I think one of the questions are about your publication, and you haven't done that yet. Is that what I heard? And that it's coming up shortly. And do you have a website that people can go to?
Yeah, there's a link to the full report of the evidence review available online, and I'll send that to you so you can send it around to participants as follow-up. but it is embedded in the PowerPoint slides. So you said
good.
Available within 48 hours on the website, so perhaps we'll just leave it at that.
Okay, perfect. I think people were just looking to share your work, and if there was a website that you guys were working on currently. I don't know if you've been continuing on different projects other than this one in regard to long-term care.
Well, all of the reviews that have been done by this team are available either through the peer-reviewed publications, but there's also a website, polypharmacy.ca, where the I think it would be summary reports that are posted there, and the key recommendations are listed there. And the nurse practitioner who runs that program, Cheryl Smith, she's one of the project partners. We had a number of project partners on this initiative who have agreed to help disseminate the findings, and so you should find them there as well.
Okay. All right. I think that's it for today. I think somebody has gotten mixed up in your name and is referring to another article, but I don't think it's yours. So I apologize. So I think that's the end of our presentation today. And again, you'll see there's the link on the slide there where both the PowerPoint and the webinar will be posted today. So thanks very much on coming today to present, and look forward to the next 3 or 4 webinars that are posted on our website. And please, everyone, feel free to register. And the actual description of each of the webinars is posted as well. So thanks for coming on today, and have a good rest of the day. Bye.
Thank you.